welcome to today's session. We have an exciting agenda for you, so thank you so much for joining us today. I'm Khili Marwaha. I'm a counseling psychologist and host for today's session. While today is all about ABA, we are truly honored to be launching applied behavior analysis at our centers. And the good news is that we have partnered with the best experts from USA to drive ABA intervention and supervision for moms believe children. And to top it all, we have not one, but two exceptional speakers who are all premier experts in ABA. With this, I would now like to introduce our speaker, Ms. Svetlana Iyer. She is a board-certified behavior analyst and a certified special educator in New York. She holds a master's degree in elementary and special education from Binghamton University and has worked in the field of special education for over 2 decades. Nonetheless, she has also received multiple medal awards in recognition of her work with ABA. Welcome to the session, Svetlana. We are so honored to have you.
Thank you, Khili. Thanks for the introduction.
With her, I would also like to introduce our co-speaker, Dr. Geetika Agarwal. Dr. Geetika is a doctorate-level behavior analyst and a licensed psychologist in the state of Washington, USA. Welcome, Dr. Geetika. We are so honored to have you.
It's my absolute pleasure to be here.
Now, I hand over the space to our amazing speakers to introduce us to ABA, its science, and its benefit. This webinar would last about 45 minutes, post which we'll open the round for Q&A. We'll be taking up questions on the first come, first serve basis. So if you have a burning question, please feel free to start typing it in the chat window. Thank you, and over to SSC.
Thanks, Khili. And I've been watching the poll as everybody's giving their responses, and I see a lot of parents in the group. So first of all, thank you so much for joining. You're spending our Saturday with us, so we particularly feel quite humbled that you decided to spend your hour with us. So I want to welcome all the parents, and then I also see we've got lots of special educators and psychologists, and we have a big other category. So whenever you guys are okay, just do feel free to write in the chat window what other describes you, because we are a big other group. So it would be nice to know, who our attendees are and who our colleagues are. With that, I will get started. And as Khili was saying, we'll answer the questions as we go. Also, feel free to write your questions in the chat window. I know between me and Svetlana, we'll tag team on who is talking and who is responding to the chat. So we want to make sure that we answer as many questions as possible, and whatever is left off, Khili is the best resource to reach us, and we'll make sure that your queries are addressed. All right, so with that, applied behavior analysis, we are starting off a really wonderful, partnership together, where we are bringing the best of the evidence-based science to mom's belief and, all the parents that are partnered with them. So today, our objective or our hope is to give a little bit of a flavor of what is ABA, and how it can help you, in either providing services to the clients that you already are seeing, or to your own kids, or wherever you might be practicing. All right, so there you go. Thanks for the introduction, Khili. So we move forward, fly past this slide. Thanks everybody for giving your introductions there. Just really quickly, we're going to talk very briefly about, a little bit about disability, what is ABA, its application, its effectiveness, and what does it really mean to be, when we say ABA versus ABA-based therapy. And then I'll hand over to Svetlana, who will take us, dive deeper into what is behavior, some about behavior acquisition, some behavior reduction procedures, etc. All right, we are probably all familiar with this number, especially if you've already been in the field. CDC estimates about 10 to 15% of the global population has some form of disability, and we have some equivalent number in India, which is quite large. There are about 1% of these folks that have some form of severe or multiple disability, and then we have equivalent numbers of that in India. And as we can see that when it comes to autism spectrum disorders in particular, an estimated numbers are around 13 to 26 million in India, which is quite large. If we were to have a similar comparison to what we see in United States, if the number is 1 in 59 children diagnosed with autism, we would say it is somewhat similar. So 1 in 100 children are diagnosed with autism, or 1 in 8 have at least some form of neurodevelopmental condition. And this is a citation from an Indian publication. It is quite consistent across countries, these numbers, and whatever variations that we might see, as we go on, understand, can be attributed to either access to diagnostic testing or just a global understanding of what is autism and its finer differentiation from other developmental delays. Again, if we were to put this into larger perspective, what does it really mean? If this blue was the total population of in India, the red little pie is the number of people with disability in India, which is similar in size to a country. Here we have an equivalence of a total population of Mexico. So the demand or the number of people in need of services is the size of whole country, which is quite significant. And I think this visual is always very powerful for us as providers to keep things into perspective when we are looking at designing services and having a wider reach for what we know or what we've been trained in, which is applied behavior analysis. So we want to make sure that this pie chart looks, if we can't shrink the size of the chart, we can at least bring services to people who are in need of therapy. Again, really quickly, we started talking a little bit about autism. We are familiar with some of the key features or diagnostic criteria. There are challenges in social interaction. There's problem in communication. We will see repetitive and restrictive behavior. And also a significant population of children diagnosed with autism tend to also present with some form of GI or gastrointestinal difficulties along with some sleep disturbances. All right. So with that background, where we know that the number of individuals diagnosed with neurodevelopmental disabilities or autism is quite large, how does or where does ABA come into play? ABA is one of the only evidence-based intervention that is known to bring about meaningful change for children who have developmental disability. But what is ABA? In essence, we would call that ABA or applied behavior analysis, it's a science, which means it is systematic and we don't go on our whims and fancies. It is very methodical. And and the whole objective is to study how the behavior is learned and then how do we change it, which means we are looking at behavior that is objective, observable, measurable, and socially meaningful. So when I say observable, what that means is I'm looking at something that I can actually see, that I can actually in some way record it. So I can probably see a child crying because there would be changing in facial expressions, there would be tears. I can see a child hitting, I can see a child falling on the floor, versus being anxious or being mad or being frustrated, because those are quite abstract emotions and I'm unable to see those. So when I'm looking at my focus is more on behavior that is observable, is measurable, it is objective, and it is socially meaningful. And then the red word that I've highlighted is essentially the ethos or the essence of our philosophy. So we are looking at behavior that has to have some impact on an individual's life, which is what makes it applied. So I apply my science of bringing about behavior change to something which is meaningful for an individual. The other part, which is analysis, this is where I examine the environment to determine what factors are influencing the behavior. So when I put an employee in a setting of one organization, how does that environment impact their productivity, or how does that environment impact their attendance or completion of the task? Similarly, if I have a child that is in a home setting, how does that impact their food intake versus when they are in their preschool, how does that impact their food intake? So this is where I actually analyze a meaningful behavior of an individual and understand what are the factors that are influencing their behavior. When we're looking at therapy, we are looking more at focus on teaching of new skills. New skills have to be, again, socially meaningful and relevant for that individual. For example, asking for preferred items, being able to use the bathroom independently, being able to board a bus, go shop in a market, and then come back home. And then also reduce some of the dangerous behavior or those behavior that might be socially inappropriate or that can actually interfere in their learning or, get in the way of social adaptive behavior. Okay, so what is it that we don't do as ABA professionals? Well, like I said, we do not talk about mental state. So in general, as service providers, we want to know how our clients are doing, So we will ask, how do you feel? We do care about you. So there is a fine line, it's not like we're like mean people and we don't really care about how you feel. But when I am being a clinician and when I am providing therapy, my focus is not so much on how you are feeling, my focus is more on your behavior. Similarly, my focus is not so much on diagnostics. Labeling. So whether you're a child with ADHD or has a pending ADHD diagnostics, or we're not sure what it might be, is there an OCD with ADHD component? My focus is not so much on label, again, because my focus is on behavior. So how does so-called ADHD presents itself? How does OCD like symptoms present itself? Because when I focus on the behavior, it helps me be a therapist and helps me be a clinician and deliver therapy. It also keeps me away from this circular reasoning about disability. So we all know the chicken and the egg, which came first, and we keep going in circle, we don't really know. But we avoid any kind of a circular reasoning, which means, and here's an example that I've written, and we use this very often. We often say that the children are running around, or this child is running around because they have an ADHD. When you ask, hey, why is the child running? You go do an observation in the classroom or in a school setting or in a home setting, and you ask, why is he running around? And the parent or the teacher might say that, oh, they've been diagnosed with ADHD. And then, you ask a mom that, hey, why did he get a diagnosis of ADHD? And the mom said, oh, because he was running around. So we kind of get stuck in this circular reasoning where we keep explaining one with the other without really having a solution to this whole presentation of behavior, where there might be sensory behavior challenges, delay in language, limited or very dysfunctional social skills. So instead of focusing on those, we get stuck on the label and we get stuck in this circle. Okay, I want to now, and I talked a lot about disability. I know I talked a lot about autism. One thing that I want to, make sure that we all understand is that ABA is not equal to autism, because we are looking at a behavior wherever there is a human being, and wherever there is a human being that is engaging in behavior, applied behavior analysis has its application. And here's a list, a variety of lists where ABA has made significant contribution. When we are looking at safe behaviors for AIDS reduction, when we are looking at business management, conservation of natural resources, how much water are we using, education or educational setting for sure, gerontology, health and exercise, industrial safety, language acquisition, littering, medical procedures, parenting, psychotherapy, seatbelt safety. So the list goes on and on and on and on and on. And I'm pretty sure that at some point, I'm assuming that people in the group would have received a WhatsApp video of Mumbai police where they were trying to reduce a honking behavior of the drivers, and every time a honking would increase beyond a certain decibel, the wait time would increase. So that is a classic and a very good example of how you can use the science of reinforcement and punishment to bring about behavior change, which is socially significant. So again, I want to drive home a point that ABA has wide-reaching impact. Now, when we look particularly for ABA as a therapy for its application for children with developmental disability, we have to go back to the landmark research of Lovas, which goes back to the years in 1987, where he was able to find and he was able to demonstrate that the group which had applied behavior analysis, they made significant gains to a point where he said 47% achieved normal IQ, 53% did not achieve normal IQ. So at that in the year 1987, that was one of the measures, an objective measure of outcome and good outcome. So he was able to demonstrate that ABA was very, very effective as opposed to that group which did not have ABA therapy. And since then, there have been plethora and like I would say thousands and thousands of research that has demonstrated long-term, short-term effectiveness of ABA therapy and its outcome. Here's another more somewhat recent publication where when they looked at longitudinal or long-term effect of ABA therapy on children with autism, they found that whether you looked at communication, their social emotional development, their adaptive behavior, or their physical development, there were positive and upward trend or positive growth across all the domains. The outcomes of the research support for ABA is so comprehensive and so strong that the National Trust has also listed applied behavior analysis as the only intervention that is supported by significant scientific evidence. So there is no denying of the fact that ABA therapy or the science of ABA, when used correctly, is extremely powerful and impactful in bringing about significant behavior change. Okay, just trying to be mindful of the time. I now have to hand it over to Svetlana as well. So I think we are making progress. I'm going to try to speed up a little bit more. Okay, now let's talk about, and I'm now realizing that I keep switching ABA therapy, ABA-based therapy back and forth. And I think because when you're in the field, you can switch the mode, but then as a person who might be attending, it can seem very confusing. So what does it really mean? Well, like we said, applied behavior analysis is a science. It is a basic philosophy where I am trying to understand how behavior was learned. And once I know that mechanism, I can now bring about change in that behavior. Once I have understanding of this science, I can then apply it. I can apply it to bring about useful change. So which is where we distinguish science from therapy. So ABA, when we say, oh, I need ABA, well, what you are really talking about is ABA based, right? You want to apply the science to or in a therapeutic format. So ABA is a science, it is not a therapy, it's not a technique. ABA-based therapy is not what we do, but how we do it, right? So it's applying the science and how we apply it. Now, there might be some tricks and procedures that we are used to seeing. We are all used to probably seeing a visual of a child on the table and a bunch of cards and, and reinforcements being delivered and whatnot. That is one way of how a science is being used. That is not ABA itself, so it's important that we have this distinction. That's just one very small way of applying a science. So ABA-based therapy is not what we do, but how we do it. It's firmly based on the principles of human learning, where how we use reinforcement, how we use punishment, how we use extinction, and some of the other concepts that we're going to talk about, how we use all of this for learning, whether it is in our clinic setting, whether it is in a school setting, whether it is for drivers, who get tickets. The minute there is a high fine in Delhi, suddenly everybody starts to drive quite well. I've been a Delhi driver myself, so I know my behavior works best for driving if it is punishment based. So if I know I will be punished by, a tulla on the side road, I'm going to drive my best. And once I know he's out of sight, I'm going to do what I need to do, right? So it is basic mechanism of human behavior and learning. Okay, here's a little bit of a grid of what we typically see in a therapeutic setup. We have ABA, we hear about speech therapy, we hear about occupational therapy. If we were to read what they really mean, ABA determines why the behavior is occurring. Speech has a focus on teaching uses different methods to teach us communication. They focus on articulation, fluency. OT wants to make sure that they follow a developmental sequence of task acquisition across lifespan. So they are all focusing on meaningful behavior, which means that if all these therapies work together and use the science of applied behavior analysis, they can all be very, very effective. So we are often, especially as parents, find ourselves that, do I need speech? Do I need OT? Do I need ABA? Well, what we ask is, how is it being provided? Because oftentimes we'll find a speech therapist who is using very effective ABA principles. So he's using the science of ABA very effectively in their speech setup. And we find that there really is no need for them to get another ABA therapist, because the science is being used so well with speech therapists. Other times we find that if we were to just put the two together and have a lot of good collaboration across the three domains, where the same reinforcement procedures are used, where the same token economy is being used, children are suddenly seeing gains across all therapies. So instead of asking, do I need one over the other, the question should be, how am I receiving speech therapy? How is OT being provided? How is ABA being provided? And that's also something that we're going to talk about. So when we look at ABA-based therapy, and I know that, Mom's Belief is going to be starting ABA, and these are some of the key features that will be in the program, because this is what distinguishes a good how a program. You always want to identify what are the desired outcomes and behaviors? What is it that we are trying to get from this therapy? And this is where family involvement is very, very important. So instead of a therapist saying that, I think your child should be counting and having a coloring program, and I think it's time for him to do potty training, it's important that this is a collaborative discussion, because we want to make sure that the outcomes are decided as a family, as opposed to just the clinicians dictating the goals. Once this is achieved, then we develop an IEP. We look at what are the existing skills of the child before we start to teach them through a very comprehensive criterion reference assessment. So before we say, yes, he can and cannot do a certain thing, we want to collect some of the baseline data. We also want to focus on some of the problem behavior, because we know that these are barriers in learning. So if you are having to spend a lot of time bringing the child back to the table, you are probably not going to have a lot of time teaching them at the table, right? So we want to work on, or a good ABA-based therapy should have a problem behavior reduction plan that is incorporated and treated directly based on the function of the problem behavior. So if the child wants my attention, hey, I want to give him attention, I just want to give it to him when he is engaging in good, appropriate behavior. In addition to that, we need continuous monitoring of the progress, which means that there has to be data collection. It can't be based on my impression. It can't be based on mood of the therapist. It can't be based on, hey, it's Monday. Monday is a bad day, so everything on Monday is just not good. That's not how we progress. That's not how we monitor progress. Has to be very objectively done. So there's continuous data collection, and we use visual analysis to understand whether or not the child was showing meaningful progress. So here's an example of a graph that we use as part of our program. We see that there's data that's being collected on the x-axis. Just to get a little more technical, on the x-axis on both the graphs, you see their dates, and the data is collected on a daily basis, because every day has significant impact. And the graph on the top is looking at skill acquisition. So we want to make sure that the child's graph should be going up, which means if whenever there's a flat line, that means he's not learning anymore. He just learned 4 things to request, and he's not learning beyond that. That's a red flag. So when I come in to supervise and I see this graph, and I ask my therapist that, why is he not asking for more things? Why is he not mastering? That lets us understand why, or what is it that we need to change. The one at the bottom is looking at problem behavior. This is where we want the behavior to go down. And here it's hitting others. And again, we collect data on a daily basis. And once we start an intervention, we want to make sure that the behavior actually goes down. If it doesn't, then I need to bring about change to my program. So these are some very, very key elements of a good ABA-based therapy, and the success of good ABA-based therapy will depend on how effectively these key elements are executed. So with that, I will hand it over to Svetlana, who is going to walk us through the rest of the wonderful elements.
Okay, thanks, Geetika. Just resharing the slides. Now, is it visible?
Yes, ma'am, it's visible.
Okay, awesome. Okay, it's visible. Okay, here we go. It wasn't moving for me. So now that Geetika has gone over a little bit of the history and the efficacy of what ABA is, let's get a little bit more in depth as to what behavior is, right? Besides being the B in ABA, behavior is any action of a living organism in relation to its environment, okay, which is physical and observable. And that's something that Geetika had just discussed a little bit in detail also. But what I'm going to share is that we look at two types of behaviors that we typically engage in. We, as human beings, have respondent, which is reflexive behavior, and we also and those are the skills that we never had to learn. Those are God-given things that we inherited, blinking, breathing, sneezing, salivation, right? If we had to learn those skills, we would be in deep trouble as a species. So those are reflexive. But the type of behavior that we are most concerned about is operant behavior. And that is the behavior that is learned. It's the behavior whose future frequency is determined by the consequences that it has met in the past, right? So, and it has a purpose, it has a function to the individual. I like this graphic that you see of the iceberg. The iceberg is on the top. It represents the behavior that we're able to observe and we're able to see. Yes, we have covert behaviors, right? Our thinking and feeling, they are covert. They're not visible to other people, but they are visible and they're observable to ourselves if we're self-aware, right? But the external, the overt behaviors are things that we are doing that are visible to other people. So for example, sitting and watching a webinar, right? Making eye contact with the person who's speaking to you, holding the door open to someone else, or requesting for water when you're thirsty, right? So all of those behaviors that are learned are really dependent on the history of reinforcement, the learning history that an individual had. And, everything that we're doing as human beings has a function. Some of them are adaptive, some of them are maladaptive behaviors, but they may serve the same function. For example, I'll tell you, if I meet an annoying person, and I think all of us have had some experience with that, how do you get rid of, interacting with an annoying person? One thing you can do is just walk away. Another thing you can do is maybe ask them to walk away. Another thing you can do is slap them, push them, and show aggression. Which behavior you exhibit really depends on what has been reinforced and what has been effective for you in the past, right? So hopefully polite manners have been reinforced for you. But what we need to look at when we're looking at behavior and establishment of behavior is the history that the individual has with any particular interaction. Okay, for some reason, my slides don't like to move well. Okay, so how do we learn these behaviors? Let's take a look at the behavior molecule. It's, as simple as ABC, but it's really not, right? ABC stands for antecedent, behavior, and consequence. Those are events, they're temporally related to each other, right? An antecedent is any environmental condition that exists prior to the behavior, right? It could be somebody saying, look, yeah? You're hearing somebody's input, look, or heads up, you duck, you avoid getting hit by a volleyball that's flying in your direction. That is the consequence. Avoidance of painful stimulus is a consequence that you received, even though you may not have felt it, but an avoidance of something is still a consequence, right? So what we do, our behavior, future probability depends on how well it worked for us, right? What kind of consequence was delivered and whether it was functional for us. So that relationship of antecedents, behavior, and consequence is what we always have to examine as a molecule from which we construct everything that we do. So let's move on to the types of behaviors that we want to see, right? Typically, everything that we exhibit as skills, right? Skills that we go to school for, skills that our parents have taught us, right? Cooperation, learner readiness, right? Visual performance, logical reasoning, mathematical abilities, imitation, motor and vocal imitation are both pivotal prerequisites for inclusion. I left out the word inclusion in there, but if you want your child or your student, your learner to be able to function independently and successfully in a typical neurotypical setting, in a general education setting, they have to have prerequisites of imitation. Monkey see, monkey do. We observe and we do the same. Those are essential skills that a lot of our learners are missing when they're early learners, and teaching them imitation skill becomes itself a very important target. Okay, group functioning, how do you interact with the group, right? ADLs are things like activities of daily living, grooming, toileting, eating, dressing self, right? All of those are skills that are acquired, nobody's born with them. And so we teach those skills. Gross motor skills, fine motor skills, language specifically. In the science of ABA, language is looked at functionally. It is not merely receptive and expressive language. We look at language through the lens of verbal behavior, which is an analysis that B.F. Skinner has developed of language using the molecule that we were talking about earlier. What are the antecedents? What are the consequences? What function does it serve for the individual, right? Academics are also a type of behavior that one exhibits. Seeing a stimulus of 2 + 2 and then writing equals 4 is a behavior, and it can be taught using reinforcement, and errors can be adjusted through other types of principles of behavior. Okay, so all of those skills and more are really taught systematically by manipulating the ABCs of behavior. Okay, verbal behavior analysis, just getting a little bit more into detailing of that, because that is one of the, just like I was talking about imitation, verbal behavior is a critical skill, and everything that falls under verbal behavior are critical skills that we learn in order to be as independent and successful in the environment. That does not mean that we always will be teaching our kids vocal verbal behavior. However, verbal behavior means it has to lead our learner or our child to be able to communicate effectively with the world. That could mean using sign language, that could mean using PECs. However, the categories and the functions of verbal behavior fall under mands, receptive, echoics, tacts, intraverbals, imitation, things like that. Let me just give you an example. Okay, coffee. We're all familiar with what that is. I've had to have a lot to stay up until this until this point in the night. For me, it's 1 o'clock in the morning. But if I wanted to have coffee, I would mand for it. Mand stands for demand or command. Okay, the function is to request. Okay, I want coffee, please. Okay, the word coffee could also be a tact. It could be a label. Tact is a term coming from contact. We contact our environment through all of our senses. We can see something and say, that's coffee. We can smell it with our eyes closed and know that that's coffee. And we can answer the question, what's that? It's coffee, right? We can also echo, right? When somebody says to me, hey, coffee is here. And I say, oh, coffee's here, right? There's an echoic in there. Listener responding is a category of language, still related to coffee, right? But it is a response to somebody else's verbal behavior, which you do non-verbally, right? So somebody says, hey, can you give me a cup of coffee? And you just hand it to them. There is a listener response, okay? It's a receptive skill. Intraverbal is ability to communicate conversationally about coffee, right? Motor imitation could be when somebody shows you the sign for coffee, you imitate coffee. Under the science of ABA and Skinner's analysis of verbal behavior, we do not consider that a learner knows a word coffee until he or she knows it across all of these functions, okay? Just because a child is able to label coffee in a picture, that does not make him a functional user of that word. Okay, what we do in ABA-based interventions and ABA-based speech and language intervention, we make sure that we focus on all functions of words and communication across all of these domains. Okay, I hope that makes sense. Okay, so what else do we work on in ABA? This is a sample skills assessment, okay? There are lots of them. This is just a snapshot of a VB map, okay? It's verbal behavior, milestones, assessment, and placement protocol, okay? So that is something that is commonly used for early learners, and it is based on typically developing children and skills that they exhibit developmentally from 0 to completion of 4 years old. What we do is we graphically look at, and everything that we do in ABA is graphic, it is visual, so that it's easy to understand and follow. We represent each of the categories, each of the functional categories of skills, whether it's MAND, tact, listen response, visual performance, play, social skills, imitation, at different levels. And we recommend specific programs that work intensively at a level which is developmentally appropriate for that learner. Just because a child is maybe 10 years old, but is nonverbal, right, does not mean that he needs to be working on multiplication and division. Prioritization of goals really is driven by criterion-based assessments, one of them being VB-MAP. The different colors that you're seeing here are representative of the different dates of assessment. So when a learner has come to us, they were assessed at, and we highlighted everything that was in yellow. The second time we did the reassessment, we highlighted the skills that he learned that are represented by the green. And then the last assessment was done, you can see in January of this year, for this learner, is represented in the purple. So every time we have an IEP review, we graphically demonstrate where the learner is. However, it does not have to be this particular assessment, but it does have to be criterion referenced, and it has to be very specific to the skills that we want to teach our children and our learners. From that assessment, we develop an IEP, right? Geetika mentioned a little bit about what an IEP is. However, just to go over, it is a written document developed specifically for each learner. It is not a school curriculum. It is not a one-size-fits-all kind of a program. It is very individualized, and it is specific to your child or to your learner that you're working with. It is based directly on the assessment that you have done. Goals and objectives describe specifically what the child will learn, right? Sometimes which target, right? The child will learn to man for coffee. Very specific objective. And what else is specified is the predetermined term, the duration of time in which you are targeting for your learner to obtain this skill. Mastery criteria for each of the objective is also clearly defined, reassessed at a minimum at the end of the term specified. For us, we target every 3 months, right? Unfortunately, in the US, also, in the public schools, it is once a year, which is not sufficient. But for an ABA-based therapy, ABA-based practice, that review is continuous. It is daily. Data is being monitored and being updated, and decisions are being made on a continuous basis. The entire reassessment is done at a quarterly basis. So some of the therapies that are going on here. I'm going to move on to demonstrating a little bit of the techniques that are used in ABA. Actually, I need to switch. Okay, so one of the things that gets to people is an ABA is a specific type of intervention and a specific type of technique. That's a myth that I want to just dispel. ABA is not discrete child training, although discrete child training is a type of technique that is involved in ABA-based therapy. It is an intensive teaching approach where we break skills down into very small parts, and each one is taught repetitively and with a lot of practice until mastery is demonstrated with that skill. And then that skill is being generalized into multiple environments across different people. But the way that we approach teaching it is through errorless learning, errorless teaching, which means that we don't give a child an opportunity to make a mistake. We give them full prompt and then we fade the prompts so that at every instance, they're experiencing success with every trial. Okay, so I wanted to show a little demo of this. Here we go. Here we go. Are you able to see the videos?
Good. Do this. Nice job. What is it? Oh, good. Vincent, what is it? Rhino. Rhino. What is it? Rhino. Good. Vincent, clap. What is it? Oh. Good. What is it? Rhino. Nice job. Do this. Good. Do this. Is that your teeth? Yeah. What is it? Candy. Candy. What is it? Candy. Good. Vincent, what's that one? What's this? Mouse. What is it? Candy. Good. What is it? Rhino. Nice. Do this. TV. TV. Tana, sure. All right.
Okay, so I'm not going to go through the whole video for the sake of time. I'm going to switch back to here. So what you just watched is a session where the therapist is repeatedly practicing specific skills and teaching them errorlessly with prompts and fading of those prompts. That's one type of technique. And there's another one that's really common, okay? That's called natural environment teaching. In this type of an approach, you will notice that a teacher follows or a therapist follows the child's lead using and contriving the child's motivation to engage in and demonstrate skills that the teacher has pre-planned. But the intention is to follow the child's interest. So let me just show you another video. I'm going to keep switching back and forth of another session, but conducted in natural environment teaching approach.
Ernie? Okay, yeah. Try Ernie. Oh, yeah. Oh, sure. Ernie has some fast feet. Max, where are your feet? Feet, there they are. Let's stomp our feet. Ready? Let's stomp, stomp, stomp. Grover, sure, we can look at Grover. Or Cookie Monster. Oh, sure. Good. The hands, let's clap our hands. Clap, 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 clap. Zoe, sure. There's Zoe. Oh, okay. I can do it for you. Zoe has orange legs. Here's your legs, Max. Legs, yeah. Big Bird. Go to Big Bird. There's Big Bird. Oh, okay.
All right. So here you saw, what you witnessed is a learner leading the session and the therapist waiting him out in order to reinforce his behavior of manding for specific characters, manding for pulling, and using spontaneous reinforcement that comes up naturally in the session. Okay. A lot of early learners benefit from natural environment training, natural environment teaching, whereas as the child establishes certain learning behaviors, certain imitative skills, manding skills, we may transition a learner to a more intensive teaching where we catch them up with more skills through DTT. And then as they progress to a more advanced learner, it is more natural to switch back to a natural environment teaching approach with them. So there's no such thing as one size fits all IEP. There's also not such a thing as one size fits all approach in ABA. It really is dependent on the functional level of the child and the learner's needs and what level of performance they're able to, demonstrate and handle. Okay, so there's one of our former kiddos. We talked a little bit about skill acquisition. Let's talk a little bit about problem behaviors as well. Okay, so there's two specific things that we focus on a lot, right? Teaching new skills and also reducing problem behaviors. Problem behavior is any behavior that interferes with learning, with play, with development, which may put the child or someone else at risk, right? There's a whole lot of problem behaviors that we see from even typically developing children. However, when it becomes a pattern, when it becomes repetitive, and it becomes disruptive to their learning process and their socialization process, then it becomes really a behavior disorder of sorts, which needs to be systematically addressed through an ABA-based intervention. Okay, so things like aggression towards others, disruptions, property destruction, right? Self-injury. Some of our learners may be biting themselves, scratching themselves. I worked with a learner who would do eye gouging and poke her eye out, and that would provide some sort of stimulation for her, which is what we determined. Stereotypy is a type of behavior which could be either proprioceptive or vocal, which is not really functional to the learner in their immediate environment, but is self-reinforcing. It feels good to do that in and of itself. Nobody has to praise you for scratching yourself when a mosquito bit you. You do that to alleviate the irritation. So it's a self-reinforcing behavior. A lot of our learners develop stereotypies, which are repetitive, continuous behaviors, which are self-reinforcing, and they may become disruptive to their learning process. Why do these behaviors come up, right? That's something that often becomes tied to the diagnosis, right? A presence of a mental or developmental disability. There's a emotional disorder of sorts. But as Geetika talked about circular reasoning, that doesn't really help us with intervention. It doesn't give us a way out, right? It just keeps going around and around. So what do we do as behavior analysts, or what do we do when we're working with a kiddo who has a problem behavior? We run a functional behavioral assessment first. We need to determine what is the purpose behind his or her problem behavior. What is he trying to achieve, right? There are systematic ways of identifying the source of reinforcement for our learners. There's indirect questionnaires, functional assessment screening tool is one that we use frequently, descriptive or structured ABC forms, and then experimental analog. All of these are in order of complexity, and the last one, the experimental analog, you would never do unless it was supervised by BCBA or in cooperation with the BCBA. So what we typically find out of those assessments, either one, it could be indirect, direct, or an analog assessment, is that our kids behave to obtain one of those things. We all do, right? We engage in behaviors to obtain social positive reinforcement, such as seeking attention or tangibles. Right now in 2020, we have really learned the value of social interaction. As human beings, we need to engage with each other and we need to interact. That's also kind of we're predetermined to be able to and to need to engage in social behavior as a species. So seeking attention is natural, but sometimes we learn to seek attention in a really disruptive or destructive manner. Seeking tangibles, looking for things that we want to eat, the activities we want to engage in, and so engaging in behaviors that get us those things is one way of obtaining that reinforcement, right? Social negative reinforcement is another reason why we may engage in certain behaviors, to avoid or escape an unpleasant stimulus, right? You hear an alarm buzzing in the morning, you engage in the pressing of the snooze button in order to escape from the annoying sound of the alarm. right? Withdrawal from an unpleasant situation or an aversive. Some of our learners learn, right? Our kids learn to behave inappropriately so that the teacher kicks them out. And the time out of the classroom actually becomes reinforcing because they get to avoid what they perceive as an unpleasant or aversive situation, okay? And as we discussed, some of the behaviors are performed or engaged in because they themselves feel good, right? And that could be behaviors that where we seek stimulation. Some of our kids like to spin in circles. We like to go on a swing and swing. That feels good to us. Or we may engage in certain behaviors that avoid painful stimulation, right? So if I'm having a headache or a migraine, my behavior then is to take a medicine which relieves the headache. That is an automatically reinforced behavior, the pill taking. Okay, so we identify which one of these functions or purposes does our learner engage in the problem behavior for, okay? And what do we do with it, right? In an ABA-based practice, what we do is we understand what the function of the behavior is. We rearrange the environment to change the antecedents and the consequences in order to teach them to obtain the same function or the same purpose, but with a socially acceptable behavior. So one of the key features is identifying the function and then teaching them appropriate replacement behavior. Okay, so if I am a nonverbal child and I am thirsty or I am hungry, I will throw a tantrum until my mom figures out what it is that I was looking for, right? But what we can do in therapy is teach the learner to request water, to ask for snacks, to independently go to the fridge and pull something out that they're seeking. Okay, so replacement behavior is a key component of problem behavior reduction. Okay, behavior intervention plan is a complement to the IEP. Okay, IEP skill acquisition, behavior intervention plan is problem behavior reduction. What it must have is definitions of target behavior that you're trying to change, which needs to be operationally defined, has to be very specific so that when mom is talking about this problem behavior, it is the same thing that we're talking about, or that dad and mom are talking about the same thing. Okay, we baseline, which means that we identify how frequently is this behavior happening prior to our intervention. We figure out what is the function, right, using one of those assessments that I was describing earlier. Identify the replacement behavior that we want to teach this child to engage in instead of that problem behavior. And then describe what are our intervention strategies, including emergency procedures, right? So that if a child starts to throw a tantrum, how are we responding to that? Sometimes not responding to a problem behavior is the required response. Right? I hope that makes sense. So for a child who is attention seeking, maybe planned ignoring of that particular tantrum is the best way to deal with that problem behavior. Okay, so intervention has to be specific to the function of the behavior. It has to be specific to what it is the child is trying to obtain. Okay, and of course, continuous evaluation and progress data has to be ongoing in order for us to evaluate or do a course correction to change the plan if it isn't working. We don't want to wait too long if something isn't working. Again, some of the pictures. Okay, ultimately, what are we trying to do here, right? Ultimately, the ABA-based therapy aims to accelerate learning of socially appropriate behaviors or skills, right? We want all of our children will learn, right, eventually. But what we are trying to do is accelerate that learning, because often enough, our kiddos have a gap between what neurotypical students are demonstrating and what our students are demonstrating. We want to catch up as much as possible, as quickly as possible. Collaboratively figure out the reasons for an individual student, why they may engage in any problem behaviors, right? So sometimes it might take input from other therapists, speech or OT, and absolutely parents. Parents are an essential part of that team that is going to work on generalizing the skills that they're learning at the center and working on reducing problem behaviors, because as families, parents and grandparents are essential environment in which the child interacts. Okay, using the knowledge to teach the student appropriate behaviors that serve the child's purpose. Again, one of the key things that we focus on is an understanding is that the child is the client. Sometimes, even if the parent is the one that's paying for the services, the goal is to make the child as independent as possible and for them to perform the skills that are going to be beneficial to them in their life, right? So working with families to understand what is the child's need, what is the child's purpose. It may be a need for the parent to put the child in a general education setting, today, but that may not be what the child needs at the moment. They may need to work on more intensively on skills that are prerequisites, and a more intensive intervention may be required before we put them into general education setting. Okay. So ultimately, plans of behavior support, right, whether it's an IEP or a BIP, define what we will do differently. Okay, as therapists, as parents, as families, as a society, it is the change in our behavior that will result in the improved behaviors of the focus person, in this case, our learner or student. Okay, and we are here to improve the students' and families' quality of life. That is the goal. All right, so why are we here? Okay, and this is a big one. And it's not the happiest slide that I'd like to talk about it, but it's the reality. All right, in India, awareness about ABA and its effectiveness and efficacy is catching up. Okay, it is catching up. People are increasingly asking for services which are evidence-based. Okay, they're seeking, and some of you, of course, as parents are probably aware how difficult, it is to find something that works. ABA works, right? We do know that from research, we know that from experience, but unfortunately, there are very few professionals who are certified in India. So the supply of professionals does not meet the demand in India. And that's the sad part. That there are currently no universities that in the country that offer ABA as a degree program. We're working on that. We're hoping to change that soon, but that limits the number of professionals that are skilled enough to conduct services and therapies at this time, because training is center-based. Okay, so where does that leave you? If you're a parent, okay, what that leaves you with is the need to educate yourselves not just on what ABA is, right, but also to look for and demand quality services that have supervision by certified professionals. That is going to be key, because if it's not available in the country, you have to look at programs that are supervised by somebody who is certified. And I hope that in some way, Mom's Belief can bring more services and more availability of ABA in India. And I hope that you'll be able to participate and it benefits your child as much as it has many children across India and across the world. So with that, we are going to conclude and thank you as we work on developing skills for our learners to move towards an inclusive program, inclusive schools, and an inclusive society. We are done. Thank you.
Thanks, Svetlana. I really want to say that we have a very, very engaged attendees. There have been so many questions about, some are more specific to, I think, their children or their clients, and other in general about ABA. So we really, really appreciate your engagement. And I think Moms Believe has really taken it upon themselves to expand the reach of applied behavior analysis across the country. And as Svetlana was mentioning, and as we've been talking about the big gap that we have in how many individuals need services and how many people are actually trained to provide good ABA therapy. And we were talking about some of the key features, and there was a question about that as well in the chat. So reach out to Moms Belief to know more about applied behavior analysis as a therapy that they're bringing to all of to all their parents. And keep your questions coming. We at Stepping Stones are quite excited about this collaboration, and are very excited to maintain the same standard that we have found to be so very effective um, for our families. And I think we feel quite honored to be able to expand it further.
So do you want to go through the questions, Geetika, and we can answer some of them?
Yeah, I've been trying to do my best to type all the answers. I know one of the questions, which I think is a good question to answer, is and yes, and we're happy to take more questions. I think one of the question was what is a good ABA therapy? What does a good ABA therapy look like? And I thought that was a very good question, and something we also talked about. And as it was interesting as I was typing, is exactly when Svetlana was talking about. And my answer was a good ABA therapy should be data driven. One thing which we were saying, it should not be based on who is the program supervisor. So whether it is Svetlana or it is me, we can't have good ABA therapy just because Svetlana is a supervisor. It should be data driven, not based on our moods or our impressions. So it has to be based on objective data. It has to be individualized to the individual, to the person for whom we are designing this therapy, or for the child who is coming to receive therapy. No two ABA programs look the same. They might start off in a similar manner. It's kind of like if you have fever, you kind of say, okay, here's a couple of fever medicines, let's see how you respond. And if it doesn't work out, then you kind of go in different directions depending upon your individual response. And it is very much like that in ABA therapy. No two children are the same, so their programs cannot be the same. The programs are very, very individualized. So if you run into a situation where you find an ABA therapist who say, I'm an ABA therapist, and here's the program book that I follow, and everybody goes through it, that's a red flag, because it's not a curriculum. What we've been saying is it's a science. It has to be individualized. Also, it has to involve parents, and parents are 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 as much a partner in this as a therapist, because it's only when we collaborate is where we see the best outcomes. Where the kids come over to the center for a couple of hours, but then they're with the therapist, with the parents for the rest of the time. So whatever little we are able to bring about, whatever little change we're able to bring about, parents are able to expand it further. And they can also tell us that, hey, this does not work in home, it works for you in the clinic, it doesn't work for you, for me at home. And then we sit together as a team and figure out, okay, how do we make it work for you at home, right? So it has to be data driven, individualized, has to involve parents who are equal partners in decision making. And again, it has to be based in research. So whenever we run into a unique situation or a unique challenge, of a behavior that we have not really seen before, we go back to data, we go back to seeing what has been done in the past in the literature, and then we come up with an intervention plan. And based on how the data looks, we make changes to it. It's kind of like whenever you're going through a medication protocol, the doctors say, okay, go get your blood test done again after 2 days, after 1 week, and then that's how I make a decision. It is very similar to that. It is based on data. It's not based on what does the doctor feel like today. It's based on what does the lab test say. So I think that was a very good question, and I'm glad that it was asked. Solana, do you want to take on a few more?
I just wanted to add to that, Geetika. I think it's important to also say that I think in general, for any therapy, for ABA therapy for sure, because we are so data driven, there's nothing to hide, right? We're only looking at how is the child responding to the interventions that we are developing? And if they're not responding to it, we have to make course corrections as soon as possible. And so there has to be a level of transparency and collaboration between a therapist and the family in order to be able to make those course corrections so that the child learns and advances as quickly as possible. It's one of my kind of, I guess, pet peeves that in many centers across India, parents complain about the fact that they're not even allowed to go inside. They don't know what's happening with therapies. It's kind of like a black hole. It is your right as a parent to see the data, even if you're not able to see the therapy session, because in certain instances, a child may respond differently to you because you become a stimulus in the environment also. But you do have a right to ask for data. What has happened in this session? What is, how is my child responding to, the intervention? And ABA is all about that. So if you're looking at quality ABA based services, like Geetika was saying, they have to be willing to be transparent with their results and share those results with you. On an ongoing basis, maybe not every day, but maybe once a week, you should be able to see the data and hopefully be able to also learn how to carry over what is being taught at school at home, because that's how you're going to maximize progress. There's a bunch of requests for specifically good speech therapists, good OTs. We cannot make those recommendations. That is just not something that we would be able to specifically advocate for. But I do believe that Moms Believe has all of those services, and whichever area you're in, they will be able to point to a therapist that matches your child's needs. Okay.
There's some question on books for ABA therapy. I think there's some good research, and we'll be happy to pass along a list of readings to Kili. I think Jalaj has also sent in an email, so we are happy to pass along some some coursework. I know Stepping Stone has a tie-up with university where we do some coursework as well. And we are also in the process of bringing about some more trainings. But I think why don't you connect with Jalaj Arora and send in your questions, and he'll forward it to us. And Kili is the person we can, we're happy to share the resources with us. So I think Moms Relief is a great way for you to direct all your ABA related questions to them. And, as your questions will present, we'll be able to, provide them with the resources. They're all very good questions. One other question that was coming in, and I don't know if people are able to unmute themselves, if they would prefer to ask a question versus write, but one of the questions was, does a child need speech, OT, does he need ABA and speech both, or all of that? So, and that's a very relevant question, and something that it's a decision that we make on a daily basis. Hey, does this child need speech therapy? Does he need OT? At what point do we discontinue speech and continue OT, or discontinue ABA and continue speech? It's a decision that we encounter on a daily basis, and the easiest way to make a decision is to look at the child and their progress and their goals. If you have a speech therapist that has made a speech evaluation, has come up with 5 goals, and the child has met all those 5 goals, and he is developmentally where he's supposed to be, and there are no more relevant goals for the child, he probably does not need speech therapy at that moment, right? Or if you have ongoing goals that are modified and updated, and you continue to see that there's progress, and the therapy is relevant for the child, then they probably do continue to see a speech therapist. Then the other is, do they need speech and ABA both? And again, that's a difficult question, because we have to look at what's the goal and what's the objective. Speech focuses on a lot of structure of language. ABA focuses a lot on, functional communication. So there's some distinction between the two. But then there's also a wide array of other objectives that are addressed in ABA therapy, which speech in some ways and occupational therapy in some ways complement, and in some way they distinguish from each other. So it's any ethical provider should not be making a blanket statement of yes and no. They should be going back to the needs of the child.
I would say, Geetika, to add to that, the best way to start for a parent is to conduct a comprehensive assessment, right? One of them that I was referring to is VB-MAP, that has different developmental categories that are represented. Another one would be ABLES, right? It's an assessment of basic language and learning skills. Also very good assessment that covers 26 different developmental areas, and performance criteria are hierarchically organized. So you can then take a look at the entire span of different skills and see where is the biggest challenge. Is it language? Is it fine motor, gross motor category? And then you can sort of uh, assign or seek services from different professionals, preferably the ones that kind of work together, because they can feed off of each other, and they can assist and cross consult, right? So that's always the best when there's an interdisciplinary approach to interventions. For older learners, an assessments such as functional skills or essential for living is one type of an assessment that looks at functional skills for older learners, vocational skills, recreational skills, besides all of the basics of language and safety skills, for example, right? So you have various types of comprehensive assessments that will give you a general idea and very specific targets to work with, also based on different developmental areas. From that, you can then create a team that works with your child. That could include a speech therapist, ABA, and an OT, or whichever way. But again, it is driven by an assessment. And then you make adjustments as the child learns and progresses. Does that make sense?
Yeah, that yes, and that's always a good point to start.
There's no feedback. I'm kind of like, I don't know. And I'm
it's a chat window. Hey, look at the chat window. There's lots of
I'm looking
questions.
at the chat, but I'm like looking for faces and what? Like, where are the faces? Okay, there was one question that was interesting. It's and you know, I'm assuming it's from a parent of you know, asking, can you describe a success story and how much time it took? It's a hard one to answer. You know, I think the best thing to do would be to look at research, right? You know, we've had lots of successes as stepping stones. There's been lots of successes in other locations. But research would indicate the best sort of way to look at possible trajectories, right? And one study that Geetika was referring to in the very beginning of the presentation is the Lovas study from the 80s that demonstrated that 47% of the children who received intensive ABA therapy for 2 years, and by intensive therapy, what they meant was 25 to 40 hours per week. It's like a full-time job for a kid to be receiving that much of intervention. For 2 years, 47% of those children were able to cross into the neurotypical range, and that was also tracked longitudinally, which means that they looked at those kids, you know, much later in their life and into adulthood, and they were still typically functioning. So it wasn't like a short-term stage which they reached, but nearly half of the kids were able to cross into the neurotypical. There's been lots of other research that showed different results, but all of them demonstrate that the more intensive it is and the earlier you start, which is typically below 5 years, the better your outcomes are, right? And the children who received no ABA therapy or received other types of therapies, maybe speech alone or OT alone, or maybe nothing, only 2% of those children have crossed into the neurotypical range. So the difference is really vast, right? However, there were so many more children that didn't make, you know, that jump, that leap into the neurotypical range. However, they all made progress with ABA. As you know, specifically autism is a spectrum disorder. There's so many different there's a range of functioning. So depending on which baseline of functioning maybe the child is, may determine how much of a leap they make. Personally, at Stepping Stones, we have had dozens of kids go through early intervention and go on to general education preschools and programs. So we have had kids who've come in older than early intervention. They've come in for intensive services, and who've also transitioned into general education setting, either independently or with some assistance. And then we also have kids who are going to be requiring therapies for the rest of their lives. But it all depends on what is the level of impact that their disability has on their functioning to begin with, right? So I can't make a prediction as to how your child will do, but I can definitely say that they will do much better with ABA, and much better with intensive ABA than they would with no ABA. I hope that makes sense. Geetika, do you have any other questions?
Yeah, I was typing some answers. Yeah, Jalaj has sent an email. So, all your questions that have that have either been left unanswered or are more specific, please do reach out to him. He has that email. And do send, I think it's helpful if you write in the subject ABA therapy with the date 19 December. What to do if telehealth session? Yeah, so Raj, it sounds like there's a lot more going on with your current situation. So please do get in touch with Killy, and I'm sure that the team at Moms Relief will be able to problem solve the situation, because yeah, certainly telehealth and telemedicine is a challenge, as we've also learned in the era of COVID. And what has been successful is going back to the key tenets, keeping it data driven, keeping it relevant for the child, and keeping the families involved, because that is a very good important variable for whether or not we are able to get close to success.
Thank
Kili,
you, Geetika. Yes, I'll just step in now, and thanks
yes.
Svetlana and Geetika for actually taking up all the questions, because I wasn't able to unmute myself. But I think definitely a lot of help was being provided. So thank you so much.
No problem.
I think we've cleared and covered all the parameters beautifully, and I'm sure this session was actually pretty helpful for, from parents to professionals to experts to students. So we have like a mixed group from the poll. We've already tried that. So thank you so much. Guys, if you have any questions, the email ID is there. Please feel free to send us the request. We're launching ABA very, very shortly, so we can start having enrollments and registrations, ASAP. So if you have any questions, definitely send us an email, and we'll be posting communication on this after this session. So I think we are good to close this session. Svetlana, Geetika, it's already too late for you. So thank you for still stretching out till 12:30. 12:20 for
I think it,
IST.
it helps when you're passionate about what you do, because yeah, we have to watch the time, otherwise it would just keep going on and on.
We could talk
We are
about
so
it,
excited. Yes.
forever. That's definitely our passion, so we don't mind.
Thank you
Yeah,
so
we
much.
are
And plus, with
really
ABA,
excited to
because
see the
we
response
are
too.
also new to ABA, so we are actually looking forward to having the best experts work with us. So we really look forward to this partnership, and let's just go on the field and start our work then.
Absolutely. Thank you so
Yeah.
much, and we're
Looking
quite
forward to it.
excited too.
Thank you everybody for joining in. Thanks for taking out time on a Saturday morning. It means a lot to all of us. So have a good day. Bye.
Bye, everyone.